Hello and welcome to today's Connect and Learn webinar. Today's webinar is part of a series of 10 Connect and Learn webinars designed to support alcohol and other drug clinicians throughout regional and metropolitan Victoria. It's hosted by Turning Point and funded by the DHHS. My name's Phoebe Spry-Bailey. I'm one of the Senior Education and Training Officers at Turning Point, and today I'll be facilitating your webinar. Before I continue though, I would like to acknowledge the traditional owners of this land upon which we are presenting and where you as participants are located, and pay our respects to elders past, present and emerging. And before we get started, just want to remind you that this webinar will run for about 45 minutes. We like our webinars to be as interactive as possible, so you will get the opportunity to complete a few online polls which will pop up throughout the presentation. And we encourage and welcome questions and comments throughout the webinar. So please just ask your questions at the chat box on the bottom left-hand side of your screen. We will be responding to your questions at the end of the session after our presentation. A PDF version of the presentation is available via the document folder, which is found on the right-hand corner of your screen. And in that document folder too, you will also find an article written by our presenter today in the conversation earlier this year. And if you're having any technical problems, Redback are here to help you out, and there is a number at the bottom of your screen if you need to get in contact. So it is with great pleasure that I introduce Dr. Shalini Arunagiri. Look, we're very excited today because we've got almost 200 registrations, and we can attribute this to our presenter and the topic that she's presenting on today. So Shalini will be providing us with an overview of the contemporary evidence on methamphetamine use in psychosis and how to integrate evidence-based approaches into practical management using a case study. And before I hand you over to Shalini, I just wanted to provide you with some background information about her. So Shalini is a clinician, researcher and senior lecturer. She works as an addiction psychiatrist and is clinical lead of statewide services at Turning Point and a senior lecturer at Monash University. She is also the chair of the Binational Faculty of Addiction Psychiatry at the Royal Australian New Zealand College of Psychiatrists. She's currently completing a PhD on methamphetamine psychosis and is passionate about delivering better care for people with co-occurring substance use and mental health problems. So I would like to hand over to Shalini, and welcome. Thank you.
Hi, thanks Phoebe, and thanks for having me as part of this Connect and Learn series. And so I've got to open with the fact that I'm a webinar virgin. This is my first webinar. I've actually never done this before. So bear with me if there are any technical difficulties through this, and as we said, please chime in the chat box if you have any problems. So today we're going to be talking about methamphetamine-associated psychosis, and as Phoebe mentioned, I've been doing a PhD on this topic. Some of you may know I've been collecting some information, some data in the last 3 or 4 years, or it seems like a really long time that I've been doing this for, but the last few years we've been collecting some information around methamphetamine psychosis and recruiting participants for our study. So today I'll give you a bit of a background around the research evidence in this area, contemporary research that provides up-to-date ideas on both how to assess for methamphetamine psychosis and also how to look at treatment approaches in clinical settings. And so my bio is there as well, but also my email address. And if you have any information about the presentation, if you want some of the references or any further details, I'm more than happy for you to contact me directly. Or through Twitter if you're on social media. So before we start, if anyone has any burning questions you were hoping to kind of get me to address during this presentation, please chime in and put that in the chat box, and I'll try to do my best to address it. During the presentation today, if there are any other questions that come up, we'll be keeping note of them, and we plan to address all of the questions at the end of the presentation. So if something does pop up that you really want us to address, just put that in and we'll keep track of that and get around to it. All right, so let's kick off. So in terms of background, in the next few slides, I'm going to talk a little bit about methamphetamine specifically. I imagine that most people have kind of chimed into this webinar, clinicians in the area, so probably don't have to spend a lot of time telling you about methamphetamine. But I'll talk to you a bit about the prevalence of methamphetamine use in Australia and in Victoria particularly, and also the health burden that we see associated with methamphetamine use. So amphetamines are a broad range of substances, and amphetamine-type stimulants are classified here as including things that include medication treatments like dexamphetamine, also includes including ecstasy, so MDMA. So when we talk about methamphetamines, they belong to this quite broad family of other drugs. But when we talk about methamphetamine specifically, we're talking about drugs that are quite frequently and widely used in Australia. I'll talk to you a little bit now about the prevalence of that. So methamphetamine forms include base and powder forms, but by and large what we know now is most people who present to treatment settings are using ice, which is a crystalline formulation. As I was saying, there are other types of amphetamine-type stimulants that aren't really reflected in sort of the literature that I'm discussing today. In terms of prevalence of methamphetamine use, in Australia, and all of this data is based on the National Drug Strategy Household Survey information from 2016, so it's fairly recent. People in Australia, if you look at people who use illicit drugs weekly or more, so these are individuals who might be using weekly or more rather than ever used in the last year. So this is reflecting regular use. In that group of individuals, methamphetamine is the second most commonly used illicit drug, unsurprisingly after cannabis. So 1 in 5 people using methamphetamine report using it weekly or more. And methamphetamines by the general public are rated the drug of most concern. So this is, related probably to the amount of media coverage associated with methamphetamine use, but it's clearly a problem that the Australian public think is really important. In terms of treatment settings, the data suggests that treatment episodes for amphetamines have really gone up, so up to 175% increase over the past 5 years, which is fairly substantial and probably something that's reflected, I think, for a lot of clinicians who are probably seeing this at the coalface. In terms of the types of methamphetamine used, and talk a little bit about this already, but on the left you've got speed, which is the powder form, and that's often smoked and snorted. Very little speed is really available on the streets nowadays in Australia. By and large, what people purchase when they purchase methamphetamine is ice. And ice is a crystalline formulation which can be smoked or injected, and we know that there are increasing proportions of people who report injecting use in Australia. And we also know that the purity of ices has gone up a lot. In terms of the prevalence of crystalline use, the most recent data suggests that most people have switched over from using powder to crystal. And of people who report using methamphetamine at all, in 2010, about 22% reported using ice or crystal. And now, the most recent data suggests that it's nearly 60% of people. And in terms of purity, now this slide's a little bit dated, but I think the information's still really salient. The average purity of methamphetamine that's based on police seizures of methamphetamine has significantly risen. So now the methamphetamine that most people purchase on the streets is upwards of 60% in terms of purity, so it's really high purity. And that we believe is related to a lot of the harms that we see associated with methamphetamine. Because the purity has gone up, people who use the drug regularly experience a lot more harms associated with it. And that's reflected in the amount of people who are reporting regular use and dependent use. So this information is from a study that was published in the Medical Journal of Australia in 2016. And if you look at that, the red and the green lines represent confidence intervals in both of those graphs. And what that means is basically if you focus on the blue line, which is the middle, basically. On the left, you've got the number of regular users. On the right, the number of dependent users. And you can see over the last decade that really there's a rising amount of regular users, but also a significant amount of people who are reporting dependent use patterns. And that's related to an acute health burden. So this is a study that was published in 2017 by Rebecca McKeaton and colleagues. And I've just created this based on the information in that study, so I encourage you to go off and read the study if you're interested. But essentially, an estimate based on a whole range of different data sets, like hospital admission data, ambulance attendance data, etc., estimated there was about 90,000 emergency department presentations and nearly 55,000 psychiatric admissions annually attributable to methamphetamine use in Australia. which is fairly significant when you hear it in those numbers. And so we did a study looking at ambulance attendances, and this was published back in 2015 in the Australian New Zealand Journal of Psychiatry. And if you look at this, we analysed non-drug related psychosis presentations. So these are people who might have, for instance, schizophrenia or bipolar disorder. That's over on the right-hand column. And on the left-hand column, it's people who presented with methamphetamine-related psychotic presentations. We looked at a whole range of different demographic factors, substance use factors, and also whether or not they had to be taken to hospital, whether or not they had to have police co-attend in the admission. And there were two, I think, important points that we found in analysing this data. Firstly, stimulant drugs, specifically mostly related to methamphetamine use, were more likely to be related to psychosis than all of the other illicit drugs combined. So that includes cannabis, and includes a whole range of other things like synthetic cannabinoids, includes MDMA, a whole range of illicit drugs. So, I think there's a clear link, certainly in our ambulance data, that suggests that methamphetamine use is associated with psychotic presentations in that data. The second thing to look at is when you look at methamphetamine-related episodes compared to non-drug-related episodes on the right, in some cases there would be what you would expect. For instance, people who had schizophrenia and bipolar disorder were more likely to have a history of psychosis. That's in the bottom row there. But also, I think I'd like to draw your attention to what isn't significant between the two groups. For instance, the amount of time the AMBOs were actually attending at the presentation in that first row. And if you look down to the fourth row, the percentage that were actually transported to hospital, that's not significant between the two groups. So this is, more information that kind of paints this picture that people who present with methamphetamine psychosis are actually associated with the amount of distress and also with burden associated with schizophrenia and other presentations. So the same proportion of people are being needed to be taken to hospital, and significant time and effort is spent in helping individuals presenting these circumstances. So moving on to specifically focusing then on psychotic symptoms in methamphetamine psychosis. In the next few slides, we'll talk about a case study, and I'll take you through a case where someone's presenting with symptoms, so we can really start to think about what we might want to be doing to intervene. We'll talk about the syndrome of methamphetamine psychosis and the symptoms and signs related to that. Now, in the next slide, we're going to launch our first poll, which we might do now. And in this poll, I want you to think about what proportion of people you think with a methamphetamine-induced psychotic disorder, how many of those individuals go on to develop schizophrenia. So here also remember, I'm talking about psychotic disorder here, and what that means is people who might have severe symptoms that require them to go into emergency department, who might present to hospital settings, like the people in that ambulance study before. We've got some votes coming in, and these are all anonymized, so I think it's great to great opportunity to kind of put your vote through. No wrong answers. There are 2 wrong answers, but there are no wrong answers anonymized. Let a few more votes come through. Yep. So we've got a range of votes coming through, and the majority of the votes are sort of suggesting about less than 10%. Yep, people who develop schizophrenia later on. Yep, we might stop that poll and keep going. So keeping that in mind, we'll tell you the answer shortly. So we'll start off with the case, okay, and this is someone who is presenting with symptoms. The 22-year-old man, this is not him, this is a photo I got off Flickr, but this is a 22-year-old man who is presenting homeless, essentially, and unemployed. He was recently kicked out of his house, and he's on Centrelink benefits. He presents now with psychotic symptoms in the context of methamphetamine use, and his symptoms have been persisting since he last used 3 weeks ago. So keep that in mind, the fact that he hasn't actually used now for about 3 weeks. Prior to that, he was using methamphetamine regularly, about 3 times a week, and he describes smoking between a point to 3 points each occasion. He also uses ecstasy on the weekends, and he talks about alcohol in terms of a binge pattern use on the weekends, up to about 20 standard drinks. He uses some other drugs as well, cannabis up to a couple of grams a day, and cigarettes as well. He smokes about 20 a day. In terms of his mental health, give you a bit more detail about his psychotic symptoms here. So he is worried that people are following him. So when he's out in public, he feels really anxious, he feels nervous. And if you ask him why he feels anxious and nervous when he's out in public, he says, oh, you know, I think some people are watching me. I think my dealer might be involved. I'm not quite sure, but I can see that people are following me. He's also been couch surfing in his friend's house. He reckons that his friends in the next room mentioned his name in conversation, and he couldn't hear the actual conversation. He couldn't figure out what the other words are, but his friend definitely said his name. He reckons his roommate might have placed a camera in his room as well, and that he's spying on him and watching him, but he says he can't be sure about that. And he's been avoiding going out lately because of how suspicious and paranoid he's been feeling. In terms of his history, and the next couple of slides cover a whole range of historical factors, and I've just given you the kind of essence of his history here, but you know, clearly in a clinical situation, this would be quite an extensive assessment to get to this point. He describes having a history of childhood trauma, and he describes having poor sort of academic achievement in school. He left at year 10 and hasn't really worked regularly since. In terms of his family history, he's got two brothers who have cannabis dependence, a father who's got alcohol and cannabis use, and a mother who's got a history of depressive symptoms. Youngest of three boys, and his dad works in the construction industry, and one of his brothers does as well. The older brother is unemployed. In terms of forensic history, which I've added there to get us thinking about how someone like this might present to a whole range of different treatment settings too. He's currently got an intervention order from his family, and that's why he got kicked out, because he punched a hole in the wall. He's got one previous assault charge whilst he was intoxicated as well. Okay, so that's our case to think about. I'm going to switch tacks a little bit, but I want you to, I've talked about the case briefly here because I want you to keep that case in mind when we go through the next few slides around the research evidence. And then we can use that to come back to it and start to think about what this means for this case and that. So psychotic symptoms, what do we mean by psychotic symptoms? Broadly speaking, this speaks to a whole range of symptoms and experiences, and what we're starting to know is that these symptoms and experiences are actually really commonly experienced across the general population. So not just associated with drug use or associated with clinical disorders, but that there's, up in some samples up to 30% prevalence of just experiencing the odd perceptual disturbance, seeing things or hearing things, or occasionally having delusional thoughts, etc. These experiences that occur in the general population, though, are often low level. They're not very severe. They're not associated with distress. When a lot of these symptoms come together, as I've shown on the right, where you might have hallucinations and suspiciousness and some of the more severe symptoms we look at, such as blunted affect or strange behavior. Take all of these things together, that's when we start to think that may be a psychotic disorder or a psychotic illness. Psychotic symptoms are really commonly experienced in acute intoxication with a whole range of drugs, so not just methamphetamine, but certainly with cannabis and with other drugs as well. So, this starts us thinking as to when is something intoxication, when is something a psychotic disorder. Should we call these sort of symptoms that occur intoxication, should we call that psychosis in itself? And there's no clear answer in a lot of these situations. Different researchers and different clinicians might think of these sort of things in different ways. But I think it's really important to be specific when we're talking about these symptoms. So we've known for a really long time that in intoxication states, methamphetamine is associated with psychotic symptoms. So this is a study that was published in 1973. And in this situation, in a lab sort of environment, gave amphetamine in an experiment to healthy volunteers in increasing doses to see what happened, essentially. And in this setting, you could nicely and really clearly show that even healthy volunteers with no sort of history of amphetamine misuse or use at all, with increasing doses of amphetamine, you could reproduce some psychotic symptoms, paranoid sort of thoughts, suspiciousness in particular. So that clearly sort of established that there was some link, but I guess the next step was trying to understand what that meant. Also importantly, in many of these settings, different people had different thresholds for developing those psychotic symptoms. So even in healthy volunteers, not everyone experienced the symptoms, and some people would take a higher dose to experience those symptoms. If you look now, and this is the answer to our question, this leads to the answer to the question in the next couple of slides. So if you look now at the prevalence of psychotic symptoms, about 1 in 3 people who use methamphetamine regularly report a history of psychotic symptoms in their lifetime. So this is if you look at people who are using methamphetamine, about once a week or more. And here we're talking about psychotic symptoms rather than a disorder. So we're talking about people who, might actually experience some paranoia, some suspiciousness, but not necessarily go to hospital for it. And this is, again, in their lifetime. So, we're asking people, have you ever experienced something like this? So unsurprisingly, these estimates vary quite a lot depending on how much you used or the pattern in which you used. So studies that have been done in recreational settings suggest that the prevalence is about 15%, up to 20%. Then you get prevalence estimates that are a lot higher than that if you look at people who are using very regularly, who are using a dependent fashion, and in treatment settings. So for instance, studies that have sampled from populations that are in psychiatric inpatient units, these people are people who have much more severe symptoms, and you see prevalence estimates up to 60% in that group. So either way, it's a fairly, it's not an uncommon problem. Now, if we look at persistent symptoms, and if you remember now, in our poll, we asked how many people would go on to develop a long-term disorder. It's interesting that the majority of us actually thought that was less than 10%. There's actually a fair amount of evidence now that suggests it's up to 30%. Which is a lot higher, I think, than we initially think as well. So if you look down there, we've got a list of references that relate to this, and most of these studies have been done in Northern Europe, where they have really good information and data sets that record people who come into hospital and when they leave and what happens to them. So these studies have been based on a 6 to 20-year follow-up, and if you follow people up then after their first hospital admission for a substance-induced psychotic disorder, follow them up to 20 years. About a third of those individuals have been re-hospitalized or re-present with substance-induced with a schizophrenia episode. So that's really a substantial proportion of people, particularly when we think that schizophrenia is a long-term illness that can be associated with significant sort of distress and also a lot of impairment. So I think when we start to think about people who present with methamphetamine psychotic symptoms, we need to think about what we can do to help prevent that trajectory. Is there anything that we can do to prevent that trajectory? I'm just going to go on to the next question now. I'm going to change tack slightly and start to think about those risk factors. We just launched that poll. Which of these risk factors do you think has the strongest association with developing psychotic symptoms in people who use methamphetamine? The whole range of risk factors there, ranging from a family history or trauma, and then a couple of methamphetamine use factors as well, frequency and injecting use as well. Some votes coming in there. Quite a lot of votes for option number 3 at the moment. Family history of psychotic illness as well. And thank you all for voting. Everyone's very active for getting in there. It's great. A couple more coming in. So we might actually start to close that off, but most people have voted for frequency, with some votes coming in there for family history of psychotic illness as the second runner. So that's really great to hear, because in the next few slides I'll talk to you about the answers to those questions. You're absolutely right. People picked number 3. Methamphetamine frequency is really up there in terms of risk factors. This is a study done back in 2013, done by Rebecca McKeaton and colleagues, and it looked at a sample that referred to as the MATES study and the MATES sample. So this was this referred to individuals who are using methamphetamine regularly and had quite a broad range of kind of patterns of drug use. So people who are using up to sort of weekly or more, but also people who are using less than that. And in that study, they looked at what happened for that individual over 3 different time points. So that's important because they weren't actually comparing, person A with person B. They were actually comparing person A against themselves at time point 1, 2, 3, and 4. So in a research study, that's really helpful because what you're doing by doing that is removing a whole lot of what we call confounding factors. For instance, person A will have the same kind of family history and background as person A again at time point B. So by comparing someone against themselves, we're actually being able to control for a lot of factors that we wouldn't otherwise be able to do. So that study was really important, sort of highlighting this issue. If you compared someone against themselves at these different time points, in the months that the person didn't use methamphetamine compared to the months where they were using, there was a 5 times increased risk of psychotic symptoms. This was a fairly dependent group of methamphetamine users, but even so, that's a substantial increase in that risk. And if you were using other drugs at that time, and they specifically talked about cannabis and alcohol in the study, there was a further increase in risk over and above that. So that graph there really shows that, I think. In terms of other risk factors, and so we were really interested in finding out, was it just methamphetamine? Were there any other non-drug related risk factors? And so we pulled together all of the studies that have been done to date looking at this, and you can go off and read the study if you're interested. It's available if you look at that bit.ly shortened website. And again, taking a whole range of studies together, again, it was the frequency of methamphetamine use that came out as really the strongest risk factor. There was some suggestion that severity of is really the strongest risk factor. There was some suggestion that severity of methamphetamine dependence also played a role. And here, those two estimates of frequency and severity often really closely related. If you're using daily or less than daily almost, then you're likely to be more severely dependent. In terms of non-drug risk factors, so risk factors that weren't related to your methamphetamine use, family history of psychosis, interestingly, was something that we thought as researchers would be very likely implicated. Interestingly, there haven't been a whole lot of studies done in this area. Only a couple of studies suggested that this was the case in the literature that we looked at, but in those studies it was a risk factor. There's only one study to date that's actually looked at a history of trauma and the role it plays, and I think this really highlights a big gap in this area. I think as clinicians we know that lots of people present with a history of trauma and with these sort of issues, so I think that's a really important area for future research. So if we think about the signs and sort of symptoms, and I guess if you're going to take on one slide from this presentation, this is probably the one that it's worth paying attention for, I think. Because I think for many clinicians, this is the problem that we really come across every day. How do you tell if someone's presenting with an intoxication problem, or if they're presenting with what we consider a psychotic disorder, or on the other hand, if they have schizophrenia or something more persistent than that? So on the left, what we think about when we talk about intoxication, moving from left to right, we look at time frames, and that helps us really kind of distinguish symptoms there. If it's been sort of in the group of 24 hours to about 3 or 4 days since the last time they've used and the psychotic symptoms have gone, it's very much more likely to be associated with an intoxication episode. If it's been persisting for more than 3 to 4 days, but up to a month by DSM-5 criteria, that would be consistent with a methamphetamine-induced psychotic disorder. Now, if it persists for more than a month, this is a little bit of a grey area. By DSM-5 diagnosis, that would be schizophrenia. By the ICD-10, which is a diagnostic criteria that's used in the UK and in many other countries, that could still be considered a methamphetamine-induced disorder. So that's following the time frame. Now, if you look at the type of symptoms that people present with, this is really interesting because the older literature, really just up to the last couple of years, seemed to suggest that there was no way you could really tell with the symptoms as to whether someone had a psychotic disorder that was going to persist or whether they had something that was methamphetamine related. In the last few years, there have been about 2 or 3 studies that have looked at this in a bit more detail, and there's some early evidence that maybe there might be some symptom differences between people who have a more persistent type of illness, between people who have symptoms that might progress on schizophrenia. So I've put those references up there if you want to go off and read about it. But essentially what we're saying is that when you have an intoxication episode, people present with more sort of visual, tactile hallucinations. So feeling, for instance, that there might be bugs or insects on their skin and feeling quite intensely sort of paranoid and suspicious. But that usually goes. In terms of a methamphetamine-used psychotic disorder, so this is where we're thinking there might be persisting symptoms. Most people present with suspicious delusions, like we saw in the case that we talked about, where people might think that people are after them or following them, and there might be some auditory hallucinations, so hearing people talking about them, hearing some conversations. Now, when we think about people who might present with what might be a more persistent illness, even in that first psychotic episode, they might talk about some symptoms that are more suggestive of a schizophrenia episode. For instance, having a more bizarre sort of delusions, more non-persecutory sort of delusions. So, for instance, not just that people are following them, but other delusional content that refers to other things. Also in the psychiatric literature, you might be familiar with some of these terms, but first-rank symptoms, which are specific kind of auditory hallucinations and specific sort of delusions. For instance, hearing that people are referring to you, or referential ideation. Also, for instance, hearing thought commentary, hearing in your own head that someone's actually talking about your thoughts, or feeling that thoughts were inserted into your mind by someone or something else. So those sort of symptoms suggest a more persistent problem. Also multimodal hallucinations, not just hearing voices, but hearing a whole range of different things and seeing things and feeling things as well. So this is really interesting sort of area of literature, and I think it really clinically very relevant because it helps us distinguish in that first episode, is this person more at risk of having something that's going to persist, that's going to actually cause a lot of problems for them later on. Coming back to our case and thinking about how that applies to Matt, our case study. So as we mentioned before, he's got actually symptoms that have persisted for 3 weeks. And so if we apply that sort of criteria, he'd probably fit under a methamphetamine-induced psychotic disorder. Now, in terms of his symptoms, again, that sort of fits in that box. Paranoid and suspicious thoughts, largely, bordering to some extent delusional content, and maybe having some auditory hallucinations. So he talked about maybe hearing his housemate saying his name, but not the actual conversations that related to it. So there's some initial symptoms there that really suggest that perhaps that's an issue for him. So now moving on from diagnosis to treatment. And here I'm going to talk about a range of treatment approaches. I'll speak briefly about treatment for methamphetamine psychosis specifically. And then I want to talk about treatment for methamphetamine dependence, because this is really relevant, given that we talked about how methamphetamine use itself was the largest risk factor for psychotic symptoms. Then I want to talk a little bit briefly about systems in this area, system approaches to this problem, and how the current systems work in sort of treating this issue. And I'll just highlight that this section 3 is the last section of our whole presentation, so if you had some questions that you were keeping, this would probably be, the next few slides would be a time to start sending them through so we can discuss them at the end. In terms of treatment for methamphetamine psychosis specifically, and there's been a little bit of research on this, mainly focusing on antipsychotic medications and looking at whether specific antipsychotic medications might work better or worse for this client group. Now, suffice to say that if you do have an intoxication sort of presentation where your symptoms are remitting within days of use, then in those cases what really needs to be done is helping the person stop using. In some cases, antipsychotic treatment might be necessary based on the severity of the symptoms, the amount of distress it's causing the person, or also the amount of distress it's causing their family members or their friends, how much risk there might be to the individual, but also to people around them. So in those cases, perhaps antipsychotic treatment might be necessary. But importantly, it's also about helping the person stop using, because that's going to make a huge difference to their prognosis. In terms of antipsychotic medication specifically, there have been a range of trials of a whole range of different antipsychotics. The older antipsychotics, like haloperidol, are associated with more side effects, so it's really the newer antipsychotics that might be more indicated. But also things to keep in mind is how long you might suggest these medications go for. And really, there's not a lot of evidence in this area to guide us. There are no clinical guidelines, for instance, or reviews that suggest anything works better than something else. What's important to remember is long-term antipsychotics might not be good for people who use methamphetamine and are dependent on it. Long-term antipsychotics probably not largely good for anyone unless it's clinically indicated, obviously. So in terms of people who are methamphetamine dependent, the particular things to think about is long-term antipsychotics can cause what we call anhedonia by acting on your dopamine receptors. And we know that that is a particular problem for people who use methamphetamine regularly. Anhedonia refers to the difficulty in terms of getting pleasure from things that you might normally enjoy. So actually, your whole reward and pleasure system gets affected. And we know that's an issue for people who are methamphetamine dependent. So medication treatments that might potentially make this worse are probably not a great idea. So the references to these studies are in the corner too, if you want to go and look them up. Coming back to methamphetamine psychosis and how I talked about methamphetamine use being the highest risk factor, what's really important in this group is really engagement, and I think that's really probably something that's quite obvious to most clinicians, but it's not always in the research as being front and center. So I think if someone presents with these sort of symptoms, what's going to be clearly obvious to everyone is just the level of suffering for that individual, but also the people around them. These symptoms are really distressing for most people. And so it's about actually being able to meet the individual where they're at and engage them in the system, engage them in treatment for their methamphetamine use, even if they're not necessarily ready to stop using at that time point, trying to look at different ways you might be able to support the person in order to do that. Now, when symptoms can be associated with risk where they might be more severe, I think it's really important that that person is referred off to see a mental health professional, whether it be a psychologist or a psychiatrist. And I know in many parts of the drug and alcohol sector that's not always easy to do, but I think it's in this particular case it's probably quite necessary because, as I mentioned before, if a third of individuals who present with these sort of symptoms then go on to develop schizophrenia, it's really important to try and see if there's any way we can intervene early in this sort of group. So we have a dual diagnosis clinic that operates at Turning Point and that operates at our Richmond and our Box Hill sites, and it's a statewide specialist clinic, so we'll see anyone who presents across the state if they have a GP referral, and we can do a psychiatry assessment and suggest both what we think of the symptoms in terms of diagnosis, but also the treatment plan. So that's available on our website. In terms of treatment now for methamphetamine dependence, going back to the point that if methamphetamine dependence is the strongest risk factor for psychosis, then helping the person stop is going to lead to symptom improvement. The treatment, importantly, that we offer in drug and alcohol services across the sector, we know that that treatment actually works really well for people with methamphetamine dependence. So, there's a lot of conversation about how the fact that there's no medical treatments necessarily for this group. We don't have opiate substitution treatment, for instance, an equivalent of that for methamphetamine users. But the treatments that we do have do work really well. And so the next couple of slides look at psychological treatments for methamphetamine dependence and sort of behavioral and structural treatments as well as psychosocial supports. So I think the reference to the slide is not here, but if you look up Turning Point's website in the Pathways study led by Victoria Manning and colleagues, these slides speak to the data from the Pathways study. That was a large study that was done across a number of states, looking at people who are coming into the drug and alcohol treatment sector and then what happened to those individuals. And here the top one and the bottom one both look at people who have methamphetamine use disorder, and methamphetamine as their primary drug of concern. And then in yellow on the top slide is people with other drugs of concern, so not methamphetamine. And you can see that actually people who cited methamphetamine as their main drug actually did a lot better across all of the treatment settings, and particularly well in terms of residential rehabilitation. If you look at reduced use in terms of treatment success, so actually reducing your use by more than 50%, again here resi rehab is number one in terms of actually working really well for this population. But the success rates are actually really high across all types of treatment. So we know that if we can get people to actually get into treatment and stay in treatment, then they're probably going to get quite a lot better. And I think that's a really important message to keep and to disseminate too, because it's not necessarily, I think, the message that, for instance, the media present or that we commonly hear about. But if we can actually get people who use methamphetamine regularly into treatment, treatment does work really well. Now, if we talk about what may be the components in treatment that do work really well, we're actually talking about psychological treatments here, and most of psychological treatments speak to cognitive behavioral therapy, or CBT, and motivational interviewing, or MI. And there's a study done back in 2005 suggesting that just 2 sessions could increase abstinence in dependent individuals. There's been some literature on ACT, or acceptance and commitment therapy, and I guess there's probably less evidence for ACT than CBT and MI in this group. But even then, 12 sessions of ACT could reduce use in this population, as long as we can keep people in treatment. Now, in terms of medication, I've already mentioned that there's not a lot of evidence for medication treatments. We looked at studies of both withdrawal and dependence, and there have been a lot of trials in this area, so it's not necessarily that there isn't enough research. Just that the research that's been done to date hasn't found anything with particularly convincing results of evidence. That includes trials of antidepressants, a whole range of stimulant medications, including dexamphetamine, methylphenidate. also antipsychotic medications and anticonvulsant medications. So across the trials, some of them improved treatment retention, but none of them really showed that there was any evidence for reducing use or abstinence. And some of the trials suggested that some of the medications might work a little bit better for craving. Now, I'm just broadly speaking to this with the caveat that we're currently updating the 2007 Turning Point Guidelines for methamphetamine use disorder. And so all of this evidence will be in that treatment guideline when it's released, probably in the next couple of months. The important thing to remember with medication treatments in this group is off-label use of medications, so using medications where it's not indicated or there's no clear evidence for it. There's a real risk there in terms of side effects and a risk of diversion or misuse. So that's particularly important in terms of stimulant medications. So if someone's prescribed stimulants to treat their stimulant dependence, so for instance dexamphetamine or methylphenidate, there is a risk that they might end up using more of that medication than they intended or that the prescriber intended, but also that medication can get diverted into the street market and might get sold on. So that's a real risk associated with stimulant medications, and so there's a whole lot of regulatory processes that clearly go into that discussion. There's also something important to keep in mind when we talk to individuals presenting with that issue. Now, a little bit of information around sort of treatment systems and treatment models. So, and here I'd be keen to hear from the audience and from the people who have tuned in as to whether they think this applies in their setting. But in lots of settings, people who present with a substance-induced psychotic disorder, for instance, psychosis, often present to acute services, like we talked about before, ambulance services or emergency departments. And from that service, they might then get admitted to an inpatient unit. From there, they might get a referral to see a drug and alcohol counselor in the community. But in terms of what happens after that, there's often not that wraparound service in terms of continuity of care. There's often not a great linkage with drug and alcohol services, and carers and family members and affected others can often get left out of that whole process as well. So there's lots of links in that process, and where there are links where the transition is, there's a risk that people fall out of the treatment sector, that they actually don't engage. And I think this is a particular problem with psychosis, where we know that what we're trying to do is a process of sort of early intervention. It's a process of trying to help someone stop before they have a long-term psychiatric illness. So it's really interesting in terms of starting to think about how can we do better in this space, how can we actually link people to treatment and keep them in treatment across acute health, across mental health, and across drug and alcohol. Coming back to our case, you might vaguely remember at this point, and someone like Matt, if he presented his services, he's really complex in terms of the number of sort of problems he's presenting with. He's got housing issues, he's got problems potentially in terms of finances, he's clearly got a methamphetamine dependence, but he also has lots of kind of risk factors there in terms of his vulnerability, in terms of his long-term risk, and in terms of his risk to others, in terms of the property damage that you already talked about in the assault. If he has psychotic symptoms, he may potentially present a risk to his roommates or his friends as well. So I think, first and foremost, being in the drug and alcohol treatment sector, that's our core business. We come back to his methamphetamine dependence and trying to help support him to reduce his use or stop using. In this case, I've already made it a bit easier on us by saying that he's gone 3 weeks without using, but that might be not necessarily realistic in day-to-day drug and alcohol treatment. So if he was still using, I think it would be really about getting him into potentially detox, whether that's home-based or residential, and supporting him in terms of care coordination and counselling. Clearly focusing on his social and psychosocial recovery through a whole range of other services that he might need to access. But in terms of his psychosis specifically, getting some clarity around the symptoms he's presenting with, and I really encourage and suggest that people consider referring him and someone like him to go off and see an addiction psychiatrist or a dual diagnosis psychiatrist to try and get a sense of where things might be headed for him, what his risk factors are, to try and get a sense of how to support him and the relationship between his mental health symptoms and his drug use. For a lot of people, getting some clarity around that and the interaction and the direction of that relationship can really help the individual too in terms of their recovery and how to move on. Now, in terms of risk, that's again where a psychiatry assessment might be indicated in terms of monitoring that risk to himself and to others, and also exploring the use of medication, whether that's indicated or not, and that might be a psychotic medication. I think it's really important to remember his parents at this point have kicked him out of his house already, and they're clearly affected in this sequelae, but also his family and his friends who are around him, his roommates, in terms of what sort of access they have to supports. And I've listed a couple of supports there, including Breakthrough, who I think this is a program that might be familiar to many people. It's ICE education for families, and it's specifically education and support for families. So if you just Google Breakthrough, you'll be able to find that support. So finishing up in terms of a summary and some take-home messages, you'll have access to this article in the documents associated with this presentation, but you can also Google it and find it quite easily. And this really summarizes a lot of the stuff we've talked about today. We've also recently published a paper, I think, that came out last week, that I haven't had time to put into this presentation. But if you look me up on Twitter, you'll be able to find that overview article. So we had an overview article in International Journal of Mental Health and Addiction that talked about methamphetamine psychosis and summarized a lot of the evidence that we've covered already today. But in summary today, what we've talked about is that psychotic symptoms are commonly experienced in people who use methamphetamine regularly, and in most people the symptoms remit if you actually help the person become abstinent from using methamphetamine. And up to a third of people who use regularly, they have severe symptoms and the symptoms can persist. But it's important to remember that treatment for methamphetamine psychosis for most people involves treatment for methamphetamine use, which we know how to do, largely speaking. So it's about offering that treatment to individuals and helping them get into the treatment sector. And we need better treatment models, I think, to offer integrated care for people who present with psychotic symptoms, for instance, in mental health settings. So I'll leave you with this point that was made by a colleague of mine, Julia Lappin, in New South Wales, really suggesting that all individuals with these sort of transient symptoms, these transient psychotic symptoms, need to be considered as a high-risk group, and they really need to be prioritized for early intervention and sort of integrated care across both mental health settings and substance use settings. Right, so that's the end of that presentation. I had a couple of questions come in, which we'll probably start to get through. But if you have any other questions as well that you haven't asked today or got you thinking about, feel free to drop us an email as well. So I might move to Phoebe.
Okay, thank you so much, Shalini. It was really fascinating webinar, and so great to have a case study embedded into it too. Now we have got a few questions that have come through. So Sam asked earlier on in the presentation, when someone mentally destabilised by ICE fronts for help, is the environment an important factor? And there's an example given here that at festival groups like DanceWise, take them to a chill zone with a soothing environment, whereas in a hospital environment they would be placed in stark, often neon lit observation room. What are your thoughts about that, Shalini?
Yeah, that's a really interesting question, and I think definitely something that's really important to think about. So if someone is intoxicated with methamphetamine, so at that moment when they're using and then they have those psychotic symptoms, I think it's really important who's around them, what's around them in terms of the environment, and also the sort of cues that are in the environment. So definitely if you're somewhere, for instance, thinking about hospital settings and emergency departments is if you're presenting with any sort of mental health symptoms, they're not the most friendly place. So, you're often around really noisy, sort of beeping noises, noisy environment, a lot of chaos and a lot of stimulus or stimulation, and often a lot of cameras in these sort of spaces as well, which can, kind of lead into people feeling more distressed and more anxious. So certainly I think hospital environments have a long way to go in terms of treating psychotic symptoms across the board and agitation across the board. I think what you're doing at DanceWise is excellent, exactly on track. Really interestingly, it's a bit of a tangent, but as part of the PhD study that I've been doing, we've been looking at social cognition, or how people relate to other people in relation to their methamphetamine use. And we found some really interesting evidence that suggests that if you're using methamphetamine and you develop psychotic symptoms, you might actually be more likely to interpret other people's emotions differently. Particularly if people are expressing anger, they might have difficulty reading anger. So that's really important in terms of thinking about how we respond to people who have methamphetamine psychosis. If they're having difficulties interpreting anger, if they're potentially misinterpreting anger as other emotions, that's really important in terms of how you actually try to help in that situation. really helping the individual feel comforted and relaxed and safe rather than actually contributing to the stress.
Thanks, Shalini. And we have another question here from Ying. How long does methamphetamine-induced psychotic disorder usually last after intoxication / withdrawal? And when would a clinician suspect an underlying psychotic disorder that was already present without or prior to use of methamphetamines?
Yep. So that's a really good question. So if you come back to that slide previously, and I'm not sure if we can bring that up again, I'll try to do that. Again, I'll get that back up for you. Yep, so if you look at this slide here, it speaks about that time frame, but I think what you're also asking is when would a clinician suspect that an underlying disorder was already there? And I think what I haven't included in the slide is getting that previous history, what actually happened prior to methamphetamine use, and that's critical as well, that's core. So, when you're assessing someone, you're asking them when do they start using methamphetamines and what sort of mental health symptoms might they have had prior to using methamphetamines before they ever used. In some people that might be hard to tell, and in some people they might not have a very long sort of period of abstinence to actually look at and look at in terms of mental health symptoms. So that's when we really suggest people might want to consider going to detox or spending some time not using it all, even if that's not their long-term goal, because during that period you can get a good sense of what's the underlying mental health state and what's actually going on. Now, in terms of how long that disorder might usually last after intoxication, so intoxication, if you've still got symptoms after kind of 4 days since your last use, you're more likely to have a methamphetamine-induced disorder than intoxication. In terms of longer than that, so if it's between a month to 6 months of this big grey area where we don't really know whether someone's got schizophrenia or methamphetamine-induced disorder in that space. So it's really about thinking about those symptoms. Again, that might give you some clues, but it's often really hard to tell.
Thanks, Shalini. And just to finish off, we do have a few comments here. Naomi has commented that to find out more about the Breakthrough program, you can go to www.breakthroughforfamilies.com. Fiona's, thanks, Shalini, for an excellent talk. And Jan's just made a comment here, which I might even get Shalini to comment on if she can. Lots of research required into addiction psychiatrists and dual diagnosis team in rural settings.
Yeah, absolutely agree, Jan. Yeah, so it's a really important area, and I think so at our Turning Point Clinic we've got telehealth assessments that allow us to do those addiction psychiatry assessments for individuals no matter where they live in the state, and we've got quite a lot of clients referred through to that service. But it's one service out of a huge population clearly that needs some help, and I think there's very few psychiatrists, broadly speaking, that work in the drug and alcohol field in Victoria, whether you're in a metropolitan setting or not. So if you look at rural, remote settings, that's an even smaller number. I think where possible, telehealth is a good option, but in some cases it can be both hard to access, but also it's hard in some cases to get some of that subtle and nuanced sort of symptom profiles across in a telehealth assessment. So in some cases, a face-to-face assessment is sometimes better. But, it's a first start. But I completely agree that, getting dual diagnosis services, broadly speaking, better researched and sort of better evidence-based and actually better supported in terms of funding is critical for this area.
Thanks, Shalini. Look, and thank you for the audience for coming along today and, participating in all the polls and asking lots of really interesting questions. And I do want to, particularly thank Shalini for taking time out of her, busy day to come along and present to us today. It's been really useful and helpful. And just before you go, I just want to mention our next Connect and Learn webinar is coming up on the 20th of June. And it's 10 Ways Motivational Interviewing Helped in My Practice. And it's presented by Helen Mentha and Sandra Rogue, who are both two experienced sort of specialists in motivational interviewing training, and they're both members of the Motivational Interviewing Network of Trainers. So we look forward to that one, and you can register via Eventbrite. And before you go today, there is a feedback survey that we'd like you to take. So please, give us your feedback because we always appreciate it. And we'll see you next time, hopefully on the 20th of June. Okay, thanks.